Welcome back. Last time we did a quick and dirty review of how jail works. Today we're going to do the same thing for the mental health side. I'm going to explain a bit about mental illness, treatment in general, and why treatment inside of a jail looks so much different than treatment in the community. So, mental illness is a pretty broad term. Usually people mean a diagnosable condition that affects your emotions, thought process, or behavior and makes it difficult for you to function. It's important for our definition to differentiate clinical disorders from everyday unpleasant experiences. With the rise of social media, it's become extremely common for people to diagnose themselves with mental health problems because they're anxious or sad or angry. I want to make it clear that experiencing unpleasant emotions is not the same thing as having a clinical disorder. Part of being human is being upset or sad or anxious. It only becomes a clinical disorder when it's been going on for a long time and it prevents you from functioning. Making a diagnosis in reality is a bit more nuanced than this, but that's usually what we're looking for. I mention this because, what do you think it feels like to be incarcerated? It can make you sad, it can make you anxious, and it can make you angry. In fact, I'd be more surprised if you were in jail and didn't experience any of these emotions. So jail itself can make people look mentally ill when they aren't, and it can make symptoms worse for people who actually are mentally ill. Next, we need to differentiate mental illness from serious mental illness, or SMI. SMI is a term of art in mental health, and it's often used in research to separate people with mental illness into groups based on severity. In short, people with mental illness have symptoms that interfere with their lives, while people with serious mental illness have symptoms which, if untreated, make it impossible for them to function independently. People with serious mental illness often pose a risk of harm to themselves or other people if they're left untreated in the community. And something worth mentioning here is that about 50% of people with a serious mental illness also suffer from anosognosia. This is another term of art in mental health which basically means that the ill person lacks awareness that he or she is ill. Anosognosia is an important concept which we'll come back to when we talk about involuntary medication and civil commitment. Now, there are some conditions which are not mental illness per se, but still often require special accommodations in a jail. These are things like autism, intellectual disabilities, and traumatic brain injuries, also known as TBIs. In each of these cases, the inmate with the condition may not need treatment, but you might end up dedicating some mental health resources to them because they don't fit in well in general population. My main concern here is that the inmate may be taken advantage of by more savvy inmates. I've seen it happen before where some of these inmates are in general population and other inmates are taking their food, stealing their PIN numbers for their phone, or in some other way exploiting their disability. So be mindful of that and work with your jail's classification department to avoid putting these inmates in general population. Next, substance use disorders. Here's another one that could really use its own video. Substance use disorders are extremely common in jails. National estimates are that 40 to 60% of jail detainees have a substance use disorder. I've run the numbers in my own jail and find that this is pretty spot on. All jails have protocols for dealing with acute substance intoxication. Most likely, your jail will have a medical department which will identify the issue and put the inmate on a detox protocol if necessary. This basically means that the inmate will be monitored by the medical staff and may receive some medication to help them deal with symptoms of withdrawal. Substance use disorders are complicated and messy, but I'll give you 3 important things to know about them up front. First, substance intoxication or brain damage due to long-term substance abuse can cause problems when you're trying to make a diagnosis. Symptoms of substance use disorders can look like depression, anxiety, psychosis, or mania. We'll often hold off on making a psychological diagnosis until the person has been in the jail for a week or more to make sure active substance abuse isn't contributing to the symptom picture. This leads me to my second point about substance abuse, which is that inmates lie about their substance use. They get arrested, brought into the booking area, and a nurse asks them how often they drink and do drugs. These inmates often think that this information will be used against them, especially if they were arrested on a DUI, and so they lie. They say they never drink or do drugs, or they say they have 1 drink a week. In my experience, everyone who tells you that they never drink or do drugs is lying to you. And also in my experience, however much someone tells you that they do drink, they're usually drinking about 3 times as much in reality. Now, you can detox from all kinds of substances, but alcohol is the most dangerous. This is because, first, symptoms of severe alcohol detox might not show up until days after the person has been arrested. And second, for someone with an alcohol dependence, detox can be fatal. We'll talk more about alcohol detox in another video, but if you are in a jail and you notice that someone who was booked in within the last week, who was acting normal at the time, is suddenly acting confused, having hallucinations, or having seizures, then you need to alert the medical team of a possible alcohol detox issue. The final thing worth noting about substance use disorders is that they are very difficult to treat in a jail. There are several reasons for this, but they include high turnover, they're not usually in the jail long enough to get treatment, frequent inmate movement between sections, a lack of qualified treatment providers relative to the quantity of the need, and a general lack of interest among the inmate population. Some jails do have designated substance abuse treatment units, but they're uncommon. In my jail, we have some substance abuse treatment inside, but the primary focus is on linking people with treatment upon their release from the jail, because the period after release from jail is often the most dangerous. Not only are people stressed out because they were in jail, and stress is a trigger for relapse, but because they get fully detoxed in jail. The danger here is that the patient might go out and use the same quantity of opioids, stimulants, or benzodiazepines that they were taking before they were in jail, but now their tolerance is gone. So it's easy to accidentally overdose. Okay, let's talk about personality disorders. A personality disorder is a pervasive and rigid pattern of thoughts that are highly resistant to change. There are several of them, but the ones you've probably heard of are antisocial personality disorder, narcissistic personality disorder, and borderline personality disorder. Personality disorders sit in this sort of strange gray area in mental illness. On the one hand, they aren't functionally crippling in the same way that more common mental illnesses are. On the other hand, they make it extremely difficult to form healthy relationships. We don't usually classify them as mental illness, in large part because there isn't much you can do about them. They are, by definition, difficult to treat. People with personality disorders usually don't recognize that they are creating their own problems, so they don't want therapy. When they do participate in therapy, they often sabotage it and then blame the therapist or someone else for failing to make progress. There's also nothing medication can do to treat a personality disorder. So, if they're not mental illness and you can't treat them, why are we talking about them? Well, the reason is that inmates with personality disorders can be extremely annoying and tend to take up a disproportionate amount of your mental health resources. They frequently act up, get into trouble, pretend to be mentally ill, and otherwise cause problems. A quick aside on this, I once had a professor tell me that an easy way to diagnose personality disorders is to use your own anger in therapy as a thermometer. The angrier your patient makes you during a session, the more likely it is that they have a personality disorder. And in my experience, this is fairly accurate. We'll go into more depth on this in a future video when we talk about malingering. Let's touch base briefly on levels of mental health care. When a person is experiencing a mental illness, the treatment should be proportionate to the severity of the symptoms. For straightforward issues, you can do outpatient therapy and/or medication management. If things are a little more serious or intense, then you can do intensive outpatient treatment or a partial hospitalization program. For serious and dangerous issues, you usually need inpatient psychiatric treatment at a hospital. These hospital stays usually range from 3 to 10 days. Finally, if the issue is both serious and chronic or resistant to treatment, there are state psychiatric hospitals, which will hold patients for 30 to 90 days, but sometimes much longer depending on the situation. Jails are full of people who could benefit from outpatient treatment. In my jail, about a third of the inmate population probably needs outpatient treatment for a diagnosed mental illness, and I'm not even including the people with substance use disorders. Jails also have a much higher percentage of those SMI diagnoses we talked about than you would find in the community. In my jail, for instance, about 4% of the inmate population have a serious mental illness that really should be treated in a psychiatric hospital. And 4% may not sound like much at first, but this is 2 to 4 times as frequent as what you would find in the community. And when you have 1,000 or more inmates in your jail, you have a lot of very acutely ill people that you're responsible for. You also get the patients who are too sick to be held in local psychiatric hospitals. I can't tell you how many times we've received a patient from a psychiatric hospital because they were assaulting the hospital staff or patients, so they were arrested and sent to us. The point is that in jail, you're dealing with the most difficult cases out there. Speaking of care, who is providing mental health care in jails? Broadly speaking, most jails contract with large medical companies that specialize in jail medicine. Sometimes the jail will partner with the local hospital, university, or counseling center and use their treatment providers. And finally, some jails will run their own in-house operation where treatment providers are county or city employees. The latter option is how my jail does it, and I highly recommend it. But we can get into the pros and cons of these options in a later video. The actual people providing the mental health care can be divided into one of two categories. These are therapy-focused providers and medication-focused providers. Each group has a hierarchy, where each step up the hierarchy means more responsibility and more treatment options. On the therapy side, you have mental health technicians, also known as mental health specialists, who are primarily tasked with crisis intervention, running groups, and monitoring inmates on suicide watch. This is usually a bachelor's degree position, but some places will hire you without one. Then you have mental health counselors and clinical social workers. These are technically different types of professionals, but when it comes to working in a jail, it's mostly a distinction without a difference. Their main role is diagnostic. They can do mental health evaluations, suicide risk assessments, and segregation assessments. They can do individual therapy and run groups, but this is usually not a good use of their time. And finally, you have clinical psychologists. That's what I am. Psychologists in jails aren't usually seeing a lot of patients individually. You're usually acting in a supervisory or administrative role. In my experience, I know a lot about a lot of different inmates in my jail, but I don't usually spend a lot of time with them. I will review the notes of the master's level therapists, provide supervision, manage projects and audits, deal with staff issues, manage the policies and procedures manual for the department, and generally make sure everything is working the way it's supposed to. Psychologists who work in jails don't usually get involved with competence evaluations for inmates in their own jail because it's considered a conflict of interest. Psychologists from the community may sometimes come into the jail to do a competence evaluation, but these are not members of the treatment team. Now, onto the medication side. You have medical assistants. They are primarily responsible for passing medication, giving injections, checking inmate vitals, and other odd administrative duties. They need at least an associate's degree and cannot prescribe medications. Next, you have nurses. Nurses don't prescribe medication, but can order medication to be administered if a prescriber has issued an as-needed order for a particular inmate. For instance, a nurse might notice that an inmate is psychotic and threatening to harm people. If there is a standing order for as-needed antipsychotics, then the nurse can make a judgment call that medication is or is not needed. Nurses also handle assessments, which are particularly important when an inmate is being booked into the jail. We'll have a whole episode about what these intake evaluations look like. Above nurses, you have nurse practitioners and physician's assistants. These providers can diagnose mental illness and prescribe medication. They may be able to do this independently, or they may need to have a collaborating psychiatrist, which depends on which state you live in. In most jails, these are the main medication providers and the backbone of jail mental health treatment. Remember that jails are not great places to do therapy, which means that medication is usually the treatment of choice. Finally, you have psychiatrists. Psychiatrists can, of course, diagnose mental illness and prescribe medication. Historically, psychiatrists were trained to do both therapy and prescribe medication, but this is really a relic of the past. I can count the number of psychiatrists I know who do therapy on 0 hands. This is largely because insurance pays a lot more for medicating patients than it does for providing therapy, which is a whole other rabbit hole we could go down, but we'll table that for now. Most psychiatrists in jails are either supervising the PAs and NPs or providing medication management for inmates. You might be wondering why they aren't doing administrative work or program development like the psychologist. The reason is, although they're qualified to do this, their ability to prescribe is simply a better use of their time. It's cheaper to get a psychologist to develop and run your program than it is to get a psychiatrist to do it. Remember, this is secretly an economics channel, so always be thinking about how the money's being spent. Now, medications themselves. For the sake of brevity, we're going to refer to them by their typical classifications, even though they don't always do what they say on the tin. These classifications are antidepressants, anxiolytics, mood stabilizers, and antipsychotics. You'll see a lot of antidepressants in jails. They're probably the most prescribed type of medication. If you've been watching this series from the beginning, you kind of know my thoughts on these, so we won't get into them here. Anxiolytics sort of come in 2 different kinds. There are the fast-acting type and the long-acting type. The long-acting type tend to be a little less potent. Those are something like hydroxyzine pamoate. Then you have the ones that are more potent and hit you quickly. These are things like lorazepam, alprazolam, and clonazepam. These work well and work quickly. However, because of this, they are commonly abused. These medications have very high trade value in jails, and if you were to somehow get a large quantity of them, it's pretty easy to overdose on them. For these reasons, most jails will not prescribe these medications other than on a short-term basis for detox. This can be an unpleasant surprise for inmates who are taking these medications daily in the community. You shouldn't be taking benzodiazepines on a daily basis anyway, but we'll save that discussion for a future video. Next, the mood stabilizers. These are things like lithium and valproic sodium. I'm trying not to use brand names here because this isn't a commercial. These medications are used to attenuate the range of the patient's mood. They're prescribed primarily for people who have mania or bipolar disorder. One of the symptoms of bipolar disorder is that you get extremely high highs and extremely low lows. These medications kind of keep you tethered in the middle. This is an effective way to prevent the worst symptoms of the illness, but most people I've talked to with bipolar disorder don't like taking these medications because they put a ceiling on your positive emotions. On a positive note, they don't have a lot of trade value. No one is trying to take lithium recreationally. Finally, we have the antipsychotics. If mental health medications were a toolbox, antipsychotics would be the hammer, at least when you're working with people with serious mental illness. At some point, we should get into the mechanism of action for antipsychotics because it's very fascinating and there are some interesting contradictions. For instance, antipsychotics are less effective the longer you take them. There are some advocacy groups that argue against the use of antipsychotics for this reason. But for now, there are two main things you need to know about them. First, they are the most effective short-term solution for someone suffering from hallucinations or delusions in a jail, assuming that the symptoms are the product of an endogenous problem rather than substance intoxication, a brain injury, syphilis, or something else. There are dozens of things that can cause a person to become psychotic, so that might be a good topic for a future video as well. The second thing you need to know is that the most effective way to administer these antipsychotics is by a long-acting antipsychotic injection, or LAI for short. These injections are basically medications that are formulated in such a way that the med is released slowly over a long period of time, usually a month or two. This is important because people who are psychotic often have anosognosia, which I explained earlier, so they don't understand that they are mentally ill and are therefore unwilling to take medication voluntarily. It's safer to give a shot involuntarily than it is to try to force someone to take a pill. The other primary benefit of an LAI is that the officers who have to hold the patient down to give the injection only have to do it once per month. I've been in a situation in which the medication we needed to give was not available in a long-acting formula, and officers had to give the shot involuntarily every day for more than a week. This is dangerous for the patient, the officers, and the MA who has to give the injection. The fewer injections you have to do, the better. Last note on this, remind me that we need to talk at some point about how and why antipsychotic injections are extremely expensive, because that situation is out of control. The last thing I wanted to touch on today is the concept that mental health providers in jails have divided loyalties. So, in the community, a clinician only has to worry about the patient, or maybe the patient and the insurance provider. But in a jail, the clinician has a duty to her patient and to the safety and security of the jail. So, for instance, an inmate might disclose that someone in his section is getting drugs from an officer. Normally, patients don't break confidentiality over someone using drugs. But this type of situation poses a potential threat to the safety and security of the jail, so the therapist may have to break confidentiality here as well. In a correctional environment, treatment decisions are driven primarily by risk and safety, and not necessarily what makes the most clinical sense. It would be great if we could just focus on treating the presenting problem, but as the inmates say, it'd be like that sometime. Jail mental health is complex and imperfect, but like it or not, jails have become the primary treatment provider for people with serious mental illness. Anyway, I'll keep making videos and keep explaining all this stuff. Now that we've got the basics out of the way, we can move on to some more specific topics. But that's all the time we have for our session today. I'll see you next week.